And now I'd like to introduce today's speaker, Dr. Athanase Benetos. Dr. Benetos is a specialist in cardiology and geriatric medicine. He has served as a research director at the National Institute of Biomedical Research and as professor of geriatric medicine and biology of aging at the University of Lorraine, where he co-founded the Cardiovascular Research Unit. He previously directed the geriatric clinic at the University Hospital of Nancy and has held multiple leadership roles within the European geriatric medicine community. His work focuses on age-related arterial changes and their clinical impact, and he has published extensively in the field. In 2023, he was elected to the French National Academy of Medicine. And now I'll turn it over to Dr. Benetos.
Well, thank you. Thank you very much for this invitation. It's a pleasure and an honor to participate this in this webinar. And so I hope you will be interested on this topic. I will present you today, and we will have enough time in order to discuss at the end. So, when we treat older patients, let's say after 80, well, there's nothing magic about this threshold of 80, but let's say over that age, you have a lot of patients, a lot of people with, let's say, more general problems of loss of autonomy, comorbidities, frailty. This is why you are talking very often, when you're talking really about old or very old, sometimes it's over 80 in our days, in our societies. But let's say, okay, so if we treat these patients, we are mainly based on one study, a very nice study actually, published more than 15, 17 years ago, yes, 2008 in New England Journal of Medicine. And at that time, we didn't know if treating these patients could have an advantage and an interest for them. And then this study shown that versus placebo, an active treatment had several benefits, as you can see here, for many endpoints, cardiovascular and total death, also cardiovascular death, and so on. So this is the main, let's say, the main source of information why to treat older people for hypertension. Well, but we have to know, and we all know, but just I remind it, that this part of the population over 80, is not only the most growing population in our society, and all over the world actually, but it's also the most heterogeneous population in terms of functionality, level of frailty, autonomy, and a lot. I mean, if you take a population, let's say it's 50, 60 years old, from the functional point of view, it's much more homogeneous than people over 80, where we have some very robust people, some very dependent people, and so on. So the question is whether the results of the HYBET study, the first slide they have shown you, can be applicable, let's say, to all or to the majority of these over 80 patients. The authors of this study, of the HYBET study, answered that question with a publication in 2015, as you can see here, and say no evidence that frailty modifies the positive impact of antihypertensive treatment in very elderly people. Okay. And they did so a post hoc analysis showing that according to the level of frailty of these patients included in the IVD study, the result was beneficial, whatever the level of frailty was. And there is another study, I didn't talk at the beginning, but the SPRINT study is not versus placebo, but it's a much more recent study, as you can see, published in about 10 years now ago. And they showed that a more intensive treatment in people over 75, it was beneficial with more ambitious, let's say, lower targets, blood pressure targets. It was so beneficial, and exploratory analysis suggested the beneficial effects was consistent among persons with or without, let's say, a kind of frailty. But in order to really answer that question, it's very important to know and to understand which are the exclusion criteria. What was the population included in these studies? Let's take the HYBET study, which again, I say it's a very good study, very interesting study, but it concerns a specific population. which are the main exclusion criteria? Someone living in a nursing home with limited autonomy or clinical dementia, even moderate, or with heart failure needing treatment with converting enzyme inhibitors, angiotensin receptor antagonists, diuretics, which means all the drugs we give in heart failure, or someone with an systolic blood pressure, low systolic blood pressure in upright position, so orthostatic hypotension, renal failure, or even any patient having a high probability of having a major health problem during the 5 years follow-up period. So this population over 18, because this was the criteria, inclusion criteria, just one of these criteria was enough to exclude from the beginning any of these patients. And if we check the sprint exclusion criteria, we have more or less the same. And in addition, exclusion criteria was type 2 diabetes, history of stroke, symptomatic heart failure within the past 6 months, and so on. You see, in all the others, it's more or less the same criteria. So the question is, does this exclusion criteria or make some difference in terms of efficacy of the treatment? Well, we don't know. But we have some, let's say, observational data that at least ask us about this question. We cannot ignore this question. Which are these? There are many observational data, but I just show you two studies. One, it's a relatively recent study, 3 years ago in hypertension, and showing on the left part in blue, they use the criteria, inclusion and exclusion criteria of the sprint study I have shown you just before. And in this part, the left part in blue, you can see that in non-frail patients, the relationship between blood pressure and cardiovascular and mortality here, it's rather, not changed until 145 or 150 or 45, and then goes up as expected, and it's also shown in younger people. But if you include those who had been excluded from the sprint study, you have a relationship that's completely different. The lower the blood pressure, the higher the risk, which is, it's somehow bothering. And of course, observational study cannot tell us what is the cause, what's the result, what's the sense of the relationship, but it's a picture, it's like a photograph, and we have to take into account. And our group, several years ago, in an observational study in nursing homes, so this is an observational study, the Partage study, we have shown in this study that people, this line here, people with low systolic blood pressure, less than 130, and at least with 2 antihypertensive medication, had double mortality as compared to all other groups with the same age and same, let's say, main characteristics. All other groups according to systolic blood pressure and presence of antihypertensive medication. So again, this is a question, why? And also, I would like to present a third result here. If we see the analysis from the British electronic health system, James Shepherd, he's in Oxford, and he showed, many other studies show that I think that's huge databases, and just few, we will not go enter the details, but you can see here, for instance, for falls, we have fit, mild frail, moderate frail, and severe frail. You see here the subgroups, again, the same thing, and the different side effects related to the medication. And you can see age adjusted. After adjustment for age, there is a clear relationship between the level of frailty and the adverse events by antihypertensive treatment. You can see here, especially for falls, for acute kidney problems, kidney injury, electrolytic abnormalities, gout, and so on. So there are some questions, and we don't know, we cannot answer. And so, for instance, from all these data or lack of data, can we decrease mortality rates? I show higher mortality rates in those with low systolic blood pressure under treatment. So can we decrease mortality in these patients if we reduce the prescribed treatment is a question. Nobody has answered so far. Which are the risks and the benefits of the prescribing antihypertensive drugs? And does the frailty level modify the benefit-risk ratio of therapeutic strategies, especially hypertension? So these are the questions we try to answer with the Retreat-Frail multicentric randomized controlled trial in nursing homes. So we took this population in which 10 years, 15 years ago, as I show you, we found an overmortality in those with low systolic blood pressure and more than one antihypertensive drugs. And we randomized this population in two parallel groups. One control group, usual care, physicians, GPs who follow these patients could continue the treatment they used to give. An intervention group, I will show you the details, where we applied an organized and standardized step-down strategy of step-down of antihypertensive treatment. The primary endpoint was all-cause mortality because this was the endpoint where we have found this difference in mortality in the observational studies. And this is so the results I will present you. The first results, the main results, predefined, of course, have been published a few months ago in the New England Journal of Medicine. Okay, I talked about the primary endpoint. You can see several secondary endpoints in this study because we wanted, as I say, the primary endpoint is can we reduce mortality when we reduce treatment? And the secondary endpoint is mainly to answer the other question, which is finally, which are the benefits and the problems of reducing treatment in these patients. What's important, and I would like to take few minutes here in this slide. I gave you the inclusion criteria, so over 80, living in nursing homes, men and women, with low systolic blood pressure and treated with more than 2 antihypertensive drugs. And some other, let's say, you can see here, but these are the main inclusion criteria. The important thing is the exclusion criteria. The exclusion criteria are almost absent. It's the opposite, exactly the opposite, let's say, of what happened so far in almost all randomized controlled trials, especially in chronic disease and risk factors like hypertension and others. I mean, in this study, we wanted to include all patients that in which we could, of course, stop at least one medication. And if someone had 2 or even 3 antihypertensive medications, but all these medications were absolutely necessary for compelling indications, other indications, we could not include them. Otherwise, and also with an estimated life expectancy, really very short, less than 3 months. Otherwise, no other exclusion criteria. All these patients, all these people that have been systematically excluded from the previous studies have been included in this study. So we have, as you will see later in this presentation, many people with high frailty. This is the nursing home population. We have also some people with rather robust, not so much, but we have some. So in order, of course, to reduce treatment, so we have to, first of all, at the moment someone was, even before randomization, at the inclusion, we took each time one of the expert physicians all over France had to classify all the antihypertensive medication of the patient in 2 lists, list 1 and list 2, as you can see here. List 1, we put the medications that could be interrupted because there was not for the given patient a strong compelling indication, heart failure, and so on. List 2 are the medications that could not be stopped because for the given patient, there was, as we can see some examples here, compelling indications. So the list 2, we put it beside, we said we don't touch this list. we can reduce only the at least one medications. We put an order, but I mean, very few patients here, for instance, central agents or alpha blockers. It's not very used in France, these medications, but it's in case, depending on what someone had, we could stop first. This was the order, a logical order, because we can say that especially for the older people, CCBs, I mean, calcium channel blockers, thiazide diuretics, and ACE inhibitors are the, let's say, the most considered as the most useful from the guidelines and generally from the different societies, academic societies as well. So this is an important issue, an important aspect of this study, and this is for the security of the patients important to do this classification before scheduling the prescription, a reduction of the treatment. The second thing is that we have very often visits in the nursing homes. The local personnel, nurses and physicians, but also our research group visited these patients for, let's say, what we call nurse visits. It's the simple visits every month during the 6 first months, and then every 2 months during the more than 3 years mean follow-up for treatment changes, to record recurrent changes, to blood pressure measurements, and for potential possible adverse events during this period. And every 3 months at the beginning, the 6 first months, and then every 6 months, we had what we call a medical visit, a physician visit, a more complete evaluation, clinical evaluation, in addition to what we measure in the nurse visits. So with clinical examination, what we call some geriatric assessment tests for gait problems, for memory problems, ADL for the autonomy evaluation, hand grip for the muscle force, and also quality of life. And also during this visits, treatment could be again only, of course, in the group of step-down strategy could be reduced, not in the intermediate visits. So the treatment reduction was at the beginning for this group of randomized in the step-down, but for the next period, it was almost always every 6 months, month 3, and then every 6 months. So this is an important issue also to go progressively. So as expected, this population, as you can see here, was a very old population at baseline, 90 years old. You can see here, and it was a rather frail population. It's not surprising, but you can see the numbers here. When we classify these patients according to the clinical frailty scale score, we can see that only less than 10% is the total, but it's very well balanced in the two groups, the baseline values. So you can see here about 9.5% of, let's say, fit patients, and about more than 38% of severely frail, and in the middle with mild or moderate frail, we have something like 30 and 22%. So rather a frail, of course, population, and a very polymedicated population. So 2.5 medications for hypertension. Maybe also these medications, as I said, sometimes are also for other compelling indications, but 2.5 medications that have antihypertensive indication, let's say. And in addition, 6.7 other concomitant medications, as you can see. So the total is more than 9, the mean, more than 9 medications per day per patient. So this population is very frail, polypharmacy, very old. And sorry, I forgot to say, of course, as expected, 80% of this population was women. This is the population in the nursing homes, as we know. I think in the United States, the same thing. And it's not only a very frail and very old population, it's a population at very high cardiovascular risk. If you see here the numbers, atrial fibrillation almost 40%. Chronic heart failure is more than 23%. Coronary heart disease, more than 20. Stroke, again, same thing. And of course, diabetes, more than 23%. And dementia, more than 45%. So it's so at the same time, a population that can benefit from medication because of all these cardiovascular events and history, but also a population that can have negative effects because of this high frailty. So this is a difficulty, and this is, I think, the value of this study. So, and here you can see the results. We obtained a significant decrease of the number of antihypertensive medications during the follow-up. In blue, you have the step-down strategy. You can see that we have also somehow a decrease in the number of medication. Also in the usual care, well, it's what we can say a kind of contamination. In the same nursing home, it was not, the randomization was not by nursing home, but individual. So in the same nursing home, we had patients in one group and the other group. So we can say we had a lot communicated before about this study. It's not impossible that some physicians who manage the usual care group had the trend also to decrease. But there is a clear difference between the two groups. And here you can see the difference in systolic blood pressure. So this decrease in treatment induced a significant, not very important, it's 4.1 millimeters, the mean all over the 3 years follow-up period. Well, at the end, we have very few patients, as you can see here, because very few patients go up to 4 years. Most patients, the mean was 3 years, 0.2. So you can see here there is a significant of about 4 or 5 millimeters of mercury between the two groups, higher blood pressure levels. The primary endpoint was identical in there's no difference between the two groups. So we don't reduce, but you don't increase either mortality when we reduce treatment by about one medication. And as you can see here, really, there is no difference. The hazard ratio, you can see here, is 1.02 with narrow 95% confidence intervals. What is interesting is this slide. You can see here is a classification. All that was pre-specified in the statistical analysis plan, of course. And you can see here we compare the two strategies in the 4 frailty groups. And we can see there is nothing significant. The interaction, as you can see here, it's P0.08. But you can see that this interaction shows that in the most robust patients, which are a small group of less than 10%, we have the impression that usual care is doing better. But if we go progressively to more frail people, the trend is different. To have more, let's say, the strategy of step down is more, let's say, favorable for these patients, the most frail. I repeat, this is a trend. It's not statistically significant, but we put this slide in our paper and here because we believe that this, and we work on that to try to understand according to the different types of frailty, physical frailty, cognitive frailty, loss of autonomy, and so on, if there are more important differences. But this is the composite score of clinical frailty scale. So, as I said, the primary and secondary endpoints, we didn't have differences in the primary endpoint. Again, I show you the 102, I show you the curves, now it's in the numbers. Of course, high levels of mortality in this population because it's 38.4 months mean follow-up. So deaths from, deaths from non-cardiovascular causes, identical. Acute heart failure, no differences. Number of falls, no differences. Number of fractures, no differences. You can see once it's one, the other, but no difference. The only thing that's different, it was deaths from COVID, because we have put that from the beginning, the statistical analysis plan. It's important because, as I told you, the study started at the middle of 2019, but most patients were included after the beginning of the pandemic, from COVID. So you can see here we have more deaths from COVID in the usual care as compared. These look low, and they are low because, as I said, the most part of the follow-up of the large majority of the patients was after the vaccination. Vaccination in France, vaccination in nursing homes, was the first population that we have vaccinated. It was the population in nursing homes from January 1st, 2021, until end of February. In 2 months, there was the first dose of the vaccine in this population, and the second one finished about April, May of 2021. And this explains why in this population, globally, the number of deaths from COVID is not very high. And the composite, as you can see, the last line composite, what we call MACE, major adverse cardiovascular events, is not different. Same thing from functional evaluations all over the study every 6 months, as I told you. Cognition, ADL, autonomy, gait and speed, SPPB, muscle force, and quality of life, no statistically significant differences. What about serious adverse events? We have no difference during this follow-up, and you can see here high numbers of side effect, adverse effects, but no difference between the two groups. So in summary, Retreat-Frail is the first randomized controlled trial to evaluate the long-term effects, long-term for this population, is more than 3 years, of antihypertensive treatment step down on mortality, morbidity, and several geriatric parameters in a large unselected population living in nursing homes, mainly female, and with the characteristics of this, the characteristics low systolic blood pressure and more antihypertensive drugs. This was the only selection, let's say. So the step-down strategy did not reduce it, the all-cause mortality. This was the primary endpoint. The step-down strategy led to a long-term reduction in antihypertensive medication. It was possible, which means because physicians had the possibility, even in the intervention group, to add again if they believe that it was harmful for their patients. They could add again the medication, and it happens sometimes, but not usually, not very often. So this is the intention to treat it's all patients, of course, that were randomized in the group of step down, and the reduction of the treatment over 3 years of follow-up was remained, significant, and resulting in a moderate increase in systolic blood pressure and diastolic blood pressure. I didn't present that. And Retreat-Frail showed that an antihypertensive treatment step-down strategy does not have a clinical relevant effect on all-cause mortality, and no other effects, does not increase problems like major cardiovascular events, other serious adverse events in a population, I repeat, which is at very high cardiovascular risk and high frailty. So we believe that the contribution of the Retreat-Frail study is that shows that the prescription of antihypertensive treatment could be considered in very old subjects with low blood pressure, especially in the frailest ones. And I'm referring to this also trend of interaction. We have a very progressive interaction from the most fit to the most frail patients in terms of benefits of the two strategies, as I showed you a few slides before. And we know that this population is the one with a lot of problems due to polypharmacy. Also, this study reminds us that the prescription is exactly as any other prescription, and which means that we have to comply with strict rules. We have to identify which are the medications that can be stopped and interrupted, which are those that cannot, which means we have to know well our patient exactly as when we prescribe a medication. And of course, after the prescription, as after any prescription, we have to monitor our patients to see which are the effects of this interruption in order to adapt our strategy. So I think this is very important and probably we'll have the opportunity to discuss. I would like to finish by really present this slide. There are many names, but this is, let's say, the network. The Retreat-Frail network was 14 university medical centers, geriatric centers, 14 in 14 different French regions all over the country. There were 110 nursing homes that included at least one patient and 108 that they randomized at least one patient. And there were all these patients, all this personnel of the nursing homes that in very difficult conditions, we were able to motivate them and to go, to move on with this study, which could be for some people was a mission impossible due to the impact at the beginning, especially before vaccination of the COVID in nursing homes. So I will stop here and I hope you have comments and questions to discuss together. Thank you very much for your attention.
Thank you, Dr. Benetos, for your excellent presentation on the Retreat-Frail study. To our audience, we would love to invite your questions. Please use the Q&A to enter your questions for Dr. Benetos. To get us started, was there anything that really surprised you in your results, thinking back on your study now?
Oh, many things. This is what in my life. So it was most of the times the initial hypothesis never the very good one. And I think it's like that also that things move on. Yes, I was expecting to have some benefits, especially maybe not for mortality, but at least for some of these, let's say, events like falls, like fractures, and we don't have. I was expecting maybe to have some more problems when we stop medication, not so major, but let's say heart decompensation, or maybe we could have more strokes because blood pressure was stopped. We don't have. So some people ask me why, if it was a good choice to make, let's say, total mortality as the main objective, the main criterion, the main endpoint, sorry. Of course, because the argument is that death, is it the most important thing in very old people? Well, I think first that death or life, it's very important anyway, independently of age. But for sure, if we choose, as I said, if we chose the total mortality, is because this is what we have mainly observed in the observational studies before. And also because it's, in order to calculate the number of patients, it's more fixed. Because death or not death, there is no any discussion. If you put some other criteria, sometimes you don't know exactly, especially in this population. For example, if you put cardiovascular mortality as a criterion, in this population, it's very difficult to say many times what is the exact cause of death, for instance. So yes, there are many surprises, but the most important thing is not to try to fit the results to what we have in our minds, but to try to change what we have in our minds according to the results. And the most important is to have a study which is, I think, from its size, duration of follow-up, number of examinations, and all the investment and quality of measurements. I think we have a huge database. We published the most, let's say, I think, important results, or what we have fixed from the beginning as main analysis, but we are still working a lot. And I can tell you also that we continue to follow up now, just without intervention, but we continue to follow up the survivors of the study for a longer period, but without having intervention to the treatment now. I mean, there is no any more randomization strategy, but just to see how things move on a longer period of time.
Thank you for that. Our audience questions are coming in. First is a thank you for this great study and presentation, and was wondering if you could comment on if there was an effect of contamination in the study and how that might help us interpret the results.
Oh, you mean the contamination, as I said, concerning the two groups? Is that right? You're talking about this contamination?
Yes.
Yeah,
yes.
From the epidemiological point, term contamination. Okay, yeah. I think that, yes. I mean, it's difficult. At the beginning, with the methodologies of this study, we have discussed about what is the most, let's say, the best strategy to do a randomization by nursing home or individual. The methodologies told us that in order to answer the same questions, if we do a randomization by nursing home, in order to avoid this contamination, we needed double of patients, double numbers, which is extremely difficult to do that. And I think it was okay. So let's say that this is, so the contamination, we can see it. For instance, when I show the decrease in the antihypertensive number of antihypertensive drugs in the control group, someone can say, okay, this is not a contamination, but it's just because as the time goes by in the usual care, people are getting, these patients who were included were getting older, and so physicians have the habit to decrease treatments when people become older. So what we did, we checked the non-antihypertensive medication, whether these medications, the number had changed over the 3 years follow-up in the usual care and in the intervention. No change at all in the number. We don't have the detailed data about the type. We work on that. But the number of I show you the beginning 6.7 medications without indication in hypertension. It's exactly the same numbers in the two groups, exactly the same 6.6, 6.7, 6, not more than that. So there is no general trend to decrease treatment. So if for the antihypertensive medication that we observed it, and about 0.3, 0.35 and medication decrease of medication in the usual care group, it is a kind of contamination. And but we have to accept that this is, many studies have this problem. Maybe you could have more important differences if we didn't have that, but we have communicated. We cannot do a study in nursing homes if we don't, previously at the beginning, if we don't communicate to the physicians why we do the study. And we said our hypothesis is we try to understand whether the reduction can help these people. But it's an open question. We don't know. So this somehow can influence the physicians in the usual care group.
Yes, thank you. It's always helpful to hear the challenges that you come through when designing these types of studies, and there's some things you just have to accept when you're looking to answer your research question. Mike, I think you have a question, so I'd like to turn it over to you.
Great. Thank you, Jonathan. Well, first and foremost, just want to congratulate you on an extremely impressive study, both in terms of the science, but also the legwork to get it done. So really an appreciation for what you've done for the field. My question, you kind of had addressed this in your slides, where there's two ways of interpreting the outcome. One is that deprescribing didn't help, so why bother? The other is that we can reduce polypharmacy in older adults without any adverse effects. So let's do that. And I'm curious, in terms of when you're talking with people who have seen the results and kind of stakeholders in the geriatrics, cardiology, nursing home communities, I'm curious what reception you've gotten in terms of those different interpretations. And also for people doing future research, whether your thoughts on whether we should be designing and powering the outcomes of our interventions to look for superiority of deprescribing, or whether looking for non-inferiority, which is kind of what you found, is the right outcome to be seeking.
Yeah. So the first comment, you're right. I mean, it's in French we say le verre à moitié plein et à moitié vide. So the glass of water is half empty, half full. I mean, something like that. So my interpretation, my conclusion is that if I can do, I mean, as well or as bad, anyway, if I can do equally with less medication in a strategy, I don't use the medication, because some people, yes, came to say, you know, it's complicated what you say. Listen, people have the medication. They have 3 medications. Okay. They have 4 medication. Okay. If they don't have problems, let's continue. And the day when if they have problems, I will stop. So I said, I don't agree. I mean, we are physicians in order, and this is our role, to always to make the balance between benefits and harms, and risks, and every strategy or every medication that it's not useful, we have to do it with, if we can do the same thing with less medication, with excluding one medication or some medication, we have always to choose that. Because even if in 3 years we don't have, we know that in this population there are risks from the polymedication, from the interactions, and if we add a new medication and so on. So I think we have my let's say, my opinion is clearly that study shows that it is possible, because so far I met the editor-in-chief of New England at the European Society of Cardiology Congress after that. And he told me one thing. I said, I'm very impressed with this study, because I couldn't imagine that we could stop medications in such a sensitive field. Cardiovascular medication is such frail and such, high risk cardiovascular risk medication. So this is why we have to, I think it's a real need for having evidence. Because so far, people, I'm talking about hypertension, is a field I know a little bit better. But working really many years, almost 40 years working in hypertension, especially in the elderly people. We have discussions and say, some people say, yes, we have to deprescribe, some others were saying no, and so on. But now we have at least one evidence for the first time. We say we can do the same thing. We don't increase the problems if we reduce treatment. Pending that, the condition is that we do that, again, I repeat that, correctly. And people who say we cannot do that correctly, because in the nursing homes or the very old people, anyway, it's very complicated to follow them up, and then it's too expensive to follow them up. I say, if we cannot follow up people when we prescribe or deprescribe, we don't do our job. This is it. This is my opinion. So for the future, I think, I would say first, for our future in this study, what we are now, it was not in the main objectives of the study, but we are trying to see, because whether there are differences in the response of these, of problems, according to which drug has been stopped. In nursing homes in France, we use, people who treat people use a lot diuretics, mainly furosemide, even if there is no heart failure, because there are edemas for many other reasons. So they give very easily furosemide, but it's also very often there is clearance of creatinine clearance that it's rather low, and so on. So, and the other medications that are extremely used are beta blockers. These are the medications. So, and of course, many people have converting enzyme inhibitors, A or Bs also, and calcium channel blockers. So we didn't explore so far. We are now doing this analysis to see whether there are differences, because maybe there are some difference between the medication. There is another also question. Okay, we stop treatment, but there are some people that their pressure goes up, some others' pressure does not go up. Does make any difference? All these questions, for the moment, we are in the main objective. Randomization, 2 groups, no difference. We are here. So for the future, I think we have to do more studies in people that are systematically excluded from these studies. My obsession, not only for hypertension, really it's an obsession, is that we cannot exclude the people from the clinical studies, people in which we give most of the medications. This is, I mean, if we say, okay, these people, we don't want to treat them. I don't at all agree with this attitude, but let's say, so I can understand that no need for clinical research in these people. But if we want to give this medication after, and we want to give strategies and to fix targets and to fix medication strategies, how comes that we don't test them? Because everybody knows that these people, it's not because they are 85, it's because many of these people of 85 have several problems. So this is, I think, something important in all domains of chronic treatments, especially risk factors. Same thing for statins, same thing for many other medications.
Terrific, thank you.
All right, our next audience question is, seeing that there was no significant difference in all-cause mortality, do you think in the future it may be more acceptable to have a slightly higher blood pressure?
To have a higher, if it's acceptable to have a higher blood pressure? This is the question?
Yeah.
Yeah. Yeah, well, again, on one hand, we have observational studies. And we all know that observational studies give, can create hypotheses, but don't give, it's low evidence. Low evidence studies, because we don't know what does it mean. But these observational studies, there are many observational studies that showing that blood pressure levels less than 130 generally are associated with high mortality. Well, so yes, I think for sure that someone with these results, I don't see, especially the most frail, where, as again, I say the trend is to the beneficial effects of less medication in this study, the trend. In these patients, I think it is completely acceptable. I don't see any study currently to say that in people, the most people 80 and over, especially with frailty, going down less than, let's say, 140 or even 150 can have benefits. The only studies that show that is for the people that are really very robust. I show you sprint study, very robust population. We cannot make afterwards. I mean, we can, but what is the meaning? Doing ad hoc, post hoc analysis, saying I will take the sprint population or the IBET population that they classify according to the frailty, while at the beginning all the frail are out. Well, I mean, there is a problem with that. It's a problem. Again, good studies, but always I say to the young people, mainly because I'm into the teaching, always when you read the study, try, first of all, go to the methods. What's the population which is concerned? I was at the 80s and 90s, I had the center, IBET center. In 2 years, I included 1 patient. Okay, maybe I'm not a well-working person, but I mean, it's not so many. Can you say in a patient 85 years old that in the next 5 years, there will not be a significant problem in his health? Yes, for some people. I mean, the marathon of Boston, there are some more in Paris or in New York. There are some people of 85 running. I love them. I love also the others that cannot make 5 steps. But this is, yeah, equally. I don't care. I don't like only the. Yes, it's less sexy, of course. But anyway, as a physician, I see the others. Okay, good. So what I do with them, this is my problem. There are people 85 that I treat them as people much younger. Why? Because they are in extremely good shape. I will go slower. I always go the steps of increasing treatments, or whatever the chronic disease is, or mostly. I go more progressively. Why? Because when I are someone who is 85, as you know, things can change more rapidly than younger people. But if someone is very well and has a pressure, let's say 130, and he's, a very good functional status, there is no reason. And this is why we have said also in the 2 years ago in the guidelines, hypertension guidelines, European Society of Hypertension, we said the most important is to check the level of functionality of people. And this is a guide. They have to guide us how to choose how aggressive we have to be. For me, this is the key point. And as I said, these problems in our societies today, not 30 years ago, it was younger at the time. Now it's over 75 or 80 where we have many people like that, not before. So from the populational level, the problem starts after that age.
All right, we have one final question for today from our audience. And they say it would be interesting to check the non-inferiority aspect of the study and all RCTs related to deprescribing benzodiazepines, anticholinergics, antipsychotic. However, wondering what is critical is the margin that should be set to define non-inferiority. And do you think it would be essential to start building literature in this area?
Yes, we can do that. The study, we cannot change. The study was what was, as I said, and when we discussed it also with the editor of New England, and this is, if you see this, the short comment also, they published 10 days ago in the paper, there is a small video. And the conclusion by the New England, it is these results make very, let's say, unlike that there is that there is an inferiority of the step-down strategy as compared to the usual care. Now, we discuss with there is another study, optimized study, which is, unfortunately, which is also older people over 80, almost the same criteria as our study, published 4 years ago in Lancet Healthy Aging by James Shepard and colleagues. And optimize, we probably will do something common to analyze together the two populations, because it's a much more healthy population. It's not in nursing homes. It's maybe you know that study actually, optimized, very nice study by James Shepard, but it's let's say rather fit patients. So the continuum is that if we put them together, we have these discussions because we worked a lot with James Shepard together in the European Society of Hypertension in other groups. So these are the results, and this, I think we will have some answers according to what is the comment here, the last comment.
All right. Well, thank you, Dr. Benetos, and thank you to all of our attendees for coming to today's webinar. The recording for today will be posted on our US Deprescribing Research Network website later this week. Our next webinar will be in the new year, so please look out for an announcement in our upcoming newsletter. Also, please complete our after webinar survey. They'll be sent to you soon. So thank you all again, and have a great rest of your day.
Thank you very much for your comments, your discussion. I saw also in the chat very interesting comments, and thank you again. And I hope we will have the opportunity again to collaborate or to discuss. Okay? Thank you.